Hi everyone. I'm so sorry for the delay. Friday the 13th AV issues is what I'm going to chalk this up to. My name's Dr. Singh. I'm one of the hepatologists here. I'm a transplant hepatologist and a gastroenterologist. I've just moved to IU, and just a little bit about me. My interests lie in liver disease and pregnancy. That includes those who develop liver disease during pregnancy, coincidentally having any kind of liver disease, and then you happen to be pregnant, but also patients who have chronic liver disease who become pregnant, both before transplant as well as after transplant. So that has been kind of what I've been doing for the last 6 years at my previous institution, and we had a very robust practice with a multidisciplinary team. And so I'm very excited to talk about one of my favorite topics today, so pregnancy and autoimmune liver disease. And this slide is just meant to give you kind of an overview. So when I talk about all these different kinds of patients that we take care of, there are a lot of different diagnoses that fall under this category. Obviously, way too many for me to talk about in just 20 minutes. So I'm going to be focusing specifically on autoimmune liver disease, primary sclerosing cholangitis, primary biliary cirrhosis, and touch a little bit on NASH and NAFLD. So an outline of the talk today, we're going to talk a little bit about how to recognize someone's having liver disease in pregnancy, talk a little bit about why it's an important topic in autoimmune hepatitis, and I will talk a little bit about the different medications that are used in autoimmune liver disease and how that may or may not affect pregnancy. And then a very brief overview on lactation and what we know about it in regards to autoimmune diseases. So, how does pregnancy compare to having cirrhosis? I talk about this a lot with my learners, that actually knowing the physiologic changes that occur in pregnancy is to actually kind of know what happens in what we call decompensated cirrhosis. So cirrhosis, advanced scarring of the liver, many times you're just at the set point, you don't even know you have it until you start to develop complications, and that's what we call decompensated cirrhosis. So in normal pregnancy and in decompensated cirrhosis, it is not abnormal to see these little spider angiomas, spider blood vessels that can form sometimes on the chest, sometimes on the hand, sometimes on the stomach, and that typically happens due to elevated estrogen levels that occur throughout pregnancy, but when your liver isn't working well, you will have that same imbalance. You can also get rosy palm. Swelling, especially at the end of a long day, is totally normal, even when you're not pregnant, but can be made a little bit worse with just the pressure the baby's putting on some of the blood vessels in the legs, and so that's common to see. And in liver disease that's been complicated, you can absolutely see all over body swelling, but also in the legs. Low blood pressure is a state that both pregnant and having liver disease, you can typically that is where you live, in a low blood pressure range, and we'll talk a little bit about why coming up. And then conditions that affect anybody, so flu, COVID, allergies tend to have a more exaggerated course, both when you're pregnant, but also when you have cirrhosis and you've had complications related to it. So the ways that they don't, that they're not similar is at the end of the day, when you're pregnant at the end of 9 months, hopefully you have a beautiful baby. And in cirrhosis, if your cirrhosis continues to stay in that tipped over decompensated state, you're probably heading to transplant. And if you go back to a set point, then you can live for years and years with just that liver disease. So I'm going to touch a little bit about some of the hemodynamic changes that occur in pregnancy. So in the first and second trimester, how much your heart pumps out really increases significantly, more so than you're used to, and then starts to kind of normalize. You really tank up your blood plasma volume. So 30 to 50% more blood pumping through your veins to support baby. and your veins lose the tone that's normally there. And that's a normal, in a normal, healthy pregnancy, that is what should happen. And so blood pressures for most pregnant women who are doing well are actually low. And you're not usually symptomatic of it. You're not feeling lightheaded and dizzy, but when they check it in the office, it's usually somewhere in the systolics being 90 to 120, that's that top number, and then the bottom number diastolic being 40s to 60s, and those are normal things. So what should liver tests look like in a normal pregnancy? So AST, ALT, which are two liver enzymes that typically are the first ones that signal that there's some kind of anomaly or inflammation in the liver, these should be normal. So whatever normal is for baseline is for somebody, it shouldn't change just because you're pregnant. Alkaline phosphatase is an enzyme in the blood that's affected by the liver but can also be affected by the placenta. And so typically as you move forward with pregnancy and the placenta gets bigger, this should go up. That's normal, nothing to be worried about. Albumin, which can sometimes be a marker of how much protein you have in your system, typically starts to go down because in this case, not because you're losing protein and because you're pregnant, part of it is because of that blood volume increasing, so it kind of dilutes it, makes it look lower, but also because albumin acutely, if you're having any kind of acute issue, a cold or an infection, it actually typically goes down. That's the way it responds. So pregnancy is actually an acute state, so it typically will go down. Bilirubin, which can make you yellow, should be normal. Prothrombin time, which is a clotting factor, that should stay the same. And alpha-fetoprotein, or AFP, is sometimes used as a tumor marker test to try to detect early liver cancer in patients. But in this case, alpha-fetoprotein is also made by the placenta. So it's normal for that to be high in pregnancy. So if you see any derangements, and especially these, AST, ALT, these transaminases, or bilirubin or protein, then you really need to seek a hepatologist advice as well as maternal fetal medicine. So why is this an important topic for autoimmune hepatitis? So, as many of you know, autoimmune hepatitis has a 4-to-1 female predominance, and typically is diagnosed at two major time points, in your reproductive years and then in your perimenopausal years. And so it actually really can affect patients who are either pregnant or trying to become pregnant. Sometimes the first time we diagnose autoimmune hepatitis is actually in pregnancy. And then actually having bad control of your autoimmune hepatitis with or without scarring has actually been associated with lower risk, lower ability to conceive, so decreased fertility. And when you get good control of the autoimmune hepatitis, that fertility is restored. I see this all the time from actually my partners, my co-hepatologist, internal medicine docs. It's very commonly thought that patients with advanced scarring cirrhosis can't get pregnant. That is not true. They absolutely can. Many of my patients do. But many of my patients will say, I'm not having any more periods, so how could I become pregnant? You're still very much likely to be ovulating even without menstruation. And that's because of that alteration in the estrogen-testosterone balance that happens with cirrhosis. And so it's really important if you're not trying to become pregnant. I make sure to counsel patients that it's very important to use contraception if you're not intending to be pregnant, because it's very likely that you're still fertile and you can still conceive. So I think I mentioned this a little bit in the beginning, but multidisciplinary care is very important if you're thinking about becoming pregnant with any kind of chronic liver disease, but especially autoimmune hepatitis and cirrhosis, and preconception counseling by both a hepatologist as well as a maternal fetal medicine doctor and or an OBGYN. So typically the team consists of OB, hepatology, maternal fetal medicine, and then also OB anesthesia as the pregnancy progresses. And that helps to account for a myriad of things, one of which in cirrhosis, whether it's compensated or decompensated, a lot of the preconception counseling we do helps to plan for endoscopies before someone gets pregnant, and then if we need to, while they're pregnant, repeating endoscopies, or if the cesarean section is planned, then any varicose veins that might be in the abdomen, just trying to do abdominal imaging beforehand to kind of pre-plan for the OB, and various medications they may need. And I'd be remiss to mention my husband's a huge Michigan fan, but it reminds me of the quote from Bosch and Beckler, the team, the team, the team. It's so important when patients with liver disease get pregnant. It's very important to have a good team. So what are some of the outcomes in autoimmune hepatitis? We have found the best outcomes to be in patients who have well-controlled disease for at least a year before trying to become pregnant. Patients who were not on any kind of immunosuppression during pregnancy who had autoimmune hepatitis were far more likely to flare during pregnancy. We do know that autoimmune hepatitis patients, when compared to the general population, that you are at higher risk for preterm birth, somewhere between 6 and 20% compared to the general population. When you compare autoimmune hepatitis patients with or without cirrhosis to patients who have any kind of chronic liver disease, whether that's fatty liver disease or alcohol-related liver disease, you don't have any increased risk of preterm birth. There is an increased risk of gestational diabetes in patients with autoimmune hepatitis who become pregnant. We don't know why. This is with or without the use of steroids. And then there is a higher risk for disorders that are specific to pregnancy. So these are liver disorders that occur in patients with or without liver disease in pregnancy, known as preeclampsia, hemolysis, elevated liver enzymes, low platelets, a syndrome known as HELP. And there is an increased risk of this in patients who have autoimmune hepatitis who become pregnant. We try to mitigate this risk. This is the only measure we have at this time by using low-dose aspirin, 162 milligrams daily between weeks 12 and 16 of gestation is when we started to try to help prevent those. So pregnancy is an immunocompromised state. Part of the reason being so that your body does not reject the fetus, there has to be an adaptation that occurs. Now, patients with autoimmune hepatitis are typically already immunosuppressed, so you're kind of doubly immunosuppressed. So some real-life cases. So this is, obviously I've changed the names and some of the details for privacy purposes, but these are some of my real patients. So Carrie is a 28-year-old. She has autoimmune hepatitis, and she's having a flare. She's been maintained on azathioprine, 50 milligrams daily, and is on a prednisone taper. She's currently at 30 milligrams. She finds out that she's pregnant and schedules an office visit. So hopefully at the end of this, I'll be able to answer all these questions. Does she need to be worried right now? What kind of monitoring do we recommend during pregnancy? And what advice would we give her in the postpartum period? So a lot of what we know about the safety of the immunosuppression we use in autoimmune hepatitis, we've actually gotten from some of the inflammatory bowel disease literature. So the PIANO study, which stands for this pregnancy and neonatal outcomes after fetal exposure to biologics as well as thiopurines like azathioprine and 6-mercaptopurine, they studied a very large cohort. So they had over 1,400 women that they followed during pregnancy and for a year after pregnancy. And as you can see, some of these patients were on no medications. Some of these patients were on thiopurines. Some of them were on biologic medications, which we don't typically use in autoimmune hepatitis. And then some were on a combination of thiopurines as well as biologics. And of that, 1,431 live births, and in that very large group of patients, they found there were no increases in congenital malformation, no increase in spontaneous abortions, no changes in preterm birth or low birth weight or infections in a year after delivery for the baby. And so It was a very large group of patients studied, so that gives us a lot of confidence. And we actually used this to extrapolate the safety of immunomodulator drugs like azathioprine and 6-mercaptopurine for autoimmune hepatitis patients, but also for my post-liver transplant patients. So a little bit about the prednisone that carries on. So prednisone, like I mentioned earlier, autoimmune hepatitis by itself, regardless of the use of steroids, is associated with increased risk of gestational diabetes. So prednisone just adds to that risk. There were old studies that suggested that prednisone use during pregnancy would cause craniofacial deformities and defects. None of the many recent studies have shown this to be the case. So safe from that perspective. Breastfeeding with high-dose prednisone has not been associated with any increased risk of infections or any adverse outcomes in the baby. There is no increased risk of miscarriage while using high-dose prednisone. There was, in that same piano study of inflammatory bowel disease patients, they did see that there were increased risks of preterm birth, as well as low birth weight, as well as restricted growth. But I suspect that had a lot to do with the fact that inflammatory bowel disease, when it's uncontrolled, you're not absorbing nutrition. And when autoimmune hepatitis is flaring, it's not necessarily the case. Most of the time, my patients don't even notice that they're flaring, other than we're checking labs and I can tell them that they're flaring. So I don't think that bit is something that we would extrapolate towards autoimmune hepatitis. But I did put that in there just to make you aware. So for Carrie, does she need to be worried right now? She should not be worried because we have a strong team that's going to take care of her. But I will be realistic with her that she does have a higher risk of complications because she's actively flaring and pregnant. So some of the things that we would do for her, we would put her on the baby aspirin. And then we would do frequent liver tests. We would check for gestational diabetes development early, and then fetal ultrasounds and non-stress testing for the baby starting at week 32 and potentially earlier. And then postpartum, that 4th trimester, we call it, the 3 months after you give birth, we watch very carefully because at that time, even if you have had quiescent disease throughout your pregnancy, that is the highest risk time for a flare. So I typically am on my patients for doing liver tests and letting me know if anything changes. It's completely safe to breastfeed with azathioprine and prednisone on board. So our second patient, Annie, she has primary biliary cholangitis with advanced scarring but not yet cirrhosis. She becomes pregnant unexpectedly. Her and her boyfriend are thrilled. They're looking forward to this. And she's been on ursodiol for the last 3 years, and she's very well controlled. So for Annie, does she need to be worried right now? No, because her liver disease has been completely controlled and in remission for over a year. And in regards to monitoring, it'd be very similar to what we did with our last patient. So every trimester I get liver tests. Every trimester we do a visit, whether virtual or in person. She also gets the baby aspirin daily. And then we make sure that she has seen either OB or high-risk OB or MFM, and that they have done counseling throughout the pregnancy, whether they're going to need to do more monitoring or not. And then postpartum, again, in that 4th trimester, we watch carefully. Ursodiol is completely fine to use in breastfeeding.
What's the baby aspirin for?
So there is, right now, the best data that we have. We don't know why preeclampsia and HELP happen physiologically. It just hasn't been fully elucidated. But the anti-inflammatory effects of aspirin have been shown to be potentially helpful in preventing that from happening. And we think the reason that preeclampsia and HELP happen have more to do in that 1st and 2nd trimester with fetal development and implantation of the, call it the trophoblast, the fetus into the uterus, and that has something to do with why those disorders develop. And so right now, the only thing, they've tried various medications. They actually tried statins, and unfortunately, none of those large studies panned out. But right now, aspirin has been shown to be helpful. So we typically, some OBs actually recommend just starting it before you even get pregnant or at the time of conception. But widely, what's been accepted is at least by week 12, you start that. Good question. And then our last patient, Jennifer, she is 35, has autoimmune hepatitis and ulcerative colitis. She's been in remission for several years and is currently taking mycophenolate mofetil, 500 milligrams twice a day, as well as adalimumab, 40 milligrams sub-Q every 2 weeks. She comes in for a routine visit and tells us that she wants to, start thinking about having kids. So what advice do we give her? So I've talked to you about many safe medications in pregnancy and autoimmune disease, and just so you know, not everything that we use is safe. Immunosuppression is not all the same. So mycophenolate mofetil in particular, it's actually the second-line medication right now, indicated for use in autoimmune hepatitis, and it is a known teratogenic medication. So 26% of pregnancies patients who are on this medication resulted in congenital defects in baby. Many pregnancies don't even make it to term because most of the time, if you're using mycophenolate, you are usually having a spontaneous abortion or a miscarriage with the use of it. We recommend strongly that we wait 12 weeks for it to completely wash out of your system before you attempt to become pregnant because of these risks that we know. In regards to male partners, this is one area that we just don't have enough research in yet. Many males are taking this for various reasons, the most common being post-transplant. We don't know if it is harmful to males whether them taking the medication affects their fertility at all. We know it doesn't affect baby, and so right now it's kind of up in the air. Most of the time I tell my male patients it's fine to take, but there are some studies that have shown that it might decrease the hardiness of the sperm, so it might make it harder to become pregnant. And then there's also not a lot of data about whether it's safe to use in breastfeeding. We think more than likely yes. There were several heart and liver transplant patients that were on this medication who were breastfeeding, and we know that it's excreted very small amounts in baby, and those babies had no negative side effects, but there just haven't been large volume studies. Now, biologic medications, for the most part, aren't used in patients who have autoimmune hepatitis, except for rituximab, which I'll talk about in a second. But those medications have been proven in that large study to be very safe during pregnancy, and then also very safe in breastfeeding. Rituximab, which is sometimes our very big gun medication that we'll use for patients who are not well controlled with their autoimmune hepatitis, is a teratogenic medication, also contraindicated in pregnancy. And so we actually ask for waiting 6 months before attempting pregnancy if that has been used, and that's an IV infusion medication. So for Jennifer, is it okay for her to become pregnant right now? No, because she is on mycophenolate, which we know is a teratogenic medication. We want to wait 3 months before it washes out of her system. And then typically, if someone is on that medication, I will switch to a third or fourth line medication that we can use for autoimmune hepatitis control. So tacrolimus, cyclosporin. Typically, they're on that medication because azathioprine didn't work, but because I know pregnancy tends to be more immunosuppressing, reinitiating azathioprine wouldn't be potentially, could be a possibility as well. We continue on the aspirin. We monitor for flares as well as all of those liver disease disorders that are specific to pregnancy. It's completely fine for her to continue taking her biologic therapy throughout the pregnancy. And then postpartum, the only difference here, because she is on a biologic infusion medication, baby cannot receive any live virus vaccines for the first 6 months. And the only vaccines that babies get in the first 6 months in the U.S. that are live virus is rotavirus. So we just ask him not to get that one. But she's completely fine to breastfeed on all these medications. And then I'm going to touch just for a second on lactation and autoimmune diseases. So breastfeeding has been proven to protect against the development of type 1 diabetes, asthma, atopic dermatitis, and allergic rhinitis, some of these which are autoimmune in etiology in the baby. So breastfeeding actually helps prevent passing on some of these things to baby. There have been several association studies done in inflammatory bowel disease and other autoimmune disease that actually shows that lactation is probably thought to be protective against the development of inflammatory bowel disease in the child. We don't yet have any research in the field of autoimmune hepatitis or PBC or PSC to show any kind of benefit or negative potential of breastfeeding in patients who have that disease. But the hope is, given these other autoimmune diseases, it's protective. The longer you lactate and for the offspring, the hope is that it would also be protective in this way. And then just a little bit about lactation and liver diseases in general. Like we mentioned, gestational diabetes is increased risk in autoimmune hepatitis. It's also associated with metabolic fatty liver disease developing in women in midlife. Lactation is known to drop maternal blood glucose. It drops the circulating lipid levels and then can improve insulin sensitivity. And so longer lactation has been associated with a lower future risk of mom developing metabolic syndrome as well as diabetes. And lactation's also been associated with a decreased risk of development of breast cancer and ovarian cancer as well as heart disease in mom. And a recent association study was done that actually showed the longer mom lactates, that actually decreases risk of fatty liver disease, which is thought to be genetic in part to baby. But also longer lactation was inversely associated with the risk of developing fatty liver disease in mom herself. So as you can see here, women who lactated somewhat, meaning somewhere between 0 to 4 weeks, versus those who lactated at least for 6 months, there was a 50% drop in those mothers when they were followed over a lifetime in the development of fatty liver disease. So lactation is actually protective for mom and baby is what it appears to be. We don't know how yet. All right, so that is all I have for you today. I'm open to any more questions. This is my email, so you guys can also email me if you have any questions. Yeah.
I have a hard time believing that it's good for a baby to have progesterone, and I mean, not progesterone, but what's that one called?
Prednisone?
Yeah, to have prednisone in a baby.
So you mean during the time that baby's in utero,
Or
or
nursing with prednisone?
for nursing?
Yeah.
There's very little steroid that gets excreted within breast milk. And so that is the reason when they actually test how much gets into the breast milk, it's very low concentration. Like for adalimumab, for instance, it's like 0.47%. And then if you think about it, baby has gastric acid and juices and everything just like we do. And so most of whatever that molecule is that does get through the breast milk, into the breast milk, gets degraded by the acids in baby's stomach. And so it's actually not been shown to be harmful for nursing.
How long did they do that study?
Sorry, I did not
How
hear.
long did they do that study? It just seems counterintuitive.
They studied it for over 1 year. Yeah, so they got baby to the 1 year. I know the new AAP recommendations are to nurse for at least 2 years, but not full-time, obviously nursing, because baby will be eating solids and things like that at that point, but to continue that bond for at least 2 years. So they did that study for 1 year.
I have a question. So for the case study that we kind of did for patient 1 and 2, you said frequent liver tests following, like in postpartum. What would be considered frequent? Like, is that weekly? Is that multiple times a week, every few weeks? And then also, what if you had to gauge the likelihood of a flare-up postpartum, what do you think the likelihood would be?
Sorry, could you use the mic? Just for, I got parts
So
of it, but
sorry.
I'm worried I didn't get all of it.
No, I was just saying, for patient 1 and 2, you were discussing having frequent liver tests in postpartum, just to monitor how the liver would react. I was curious how often those tests would be. And the second part to that was, I'm blanking on it. Oh, what do you think the likelihood of a flare would be during postpartum?
Yeah, okay, that's a great question. So my typical frequency during pregnancy is once every trimester. So every 3 months, essentially, 3 to 4 months, which most of my patients are getting. If you're on azathioprine, you're getting labs from me every 3 months anyway, just to make sure your CBC stays normal. In that postpartum period, I typically will not make you do labs more than once a month. And that, again, part of it depends on if you went into pregnancy being really well controlled for over a year, then, that's what I will do. If you went into pregnancy and you were flaring in pregnancy, then that changes the equation for me. I will probably be watching you so much more like a hawk in that postpartum period especially. But in the postpartum period, I also know I can use everything, so because it's still safe for if you decide to continue to nurse, it's still safe for baby, and you're no longer pregnant in that postpartum period. So I can use most of everything in my arsenal. So probably once a month in that 4th trimester if you've been well controlled, and then potentially more frequently if you haven't been well controlled in the pregnancy or right before the pregnancy. Mm-hmm.
Can you comment on any observations of patients women taking prednisone along with their hormonal imbalances during pregnancy as well as postpartum?
Yeah, so my patients they don't have great side effects of taking the prednisone, absolutely. I mean, because already, especially in the 2nd and 3rd trimester of pregnancy, you have the normal kind of pregnancy aches and pains, but it is safe. I have used it often, not necessarily for autoimmune hepatitis, but we've had to use it in other patients with other conditions. It's completely safe, but will my patients be miserable with insomnia? Yes. Surprisingly, most of, anecdotally from my experience, my patients don't necessarily feel hungry or want to eat everything in sight. Part of that, I think, is because babies, taking up quite a bit of room. But the insomnia is definitely there. Swelling is definitely there. Blood glucose levels being out of control absolutely can happen and tends to be worse as you get farther along in the pregnancy. But overall, most of the studies that have been done with autoimmune liver disease, the risks of using, those side effects associated with prednisone, the benefits outweigh that risk. Because if you can get that, your autoimmune hepatitis under control, that was a far better outcome for both baby and mom.
Is there a higher risk of a postpartum flare if you develop HELP or cholestasis during pregnancy?
If you develop what?
If you develop HELP or preeclampsia or cholestasis during pregnancy?
That's a great question. I don't think that's been looked at all. From all of the studies that I have reviewed, that association has not been looked at. But that's a good question. I would think. I mean, again, knowing that we don't know the true pathophysiologic basis for HELP and ICP and all those other things, what I understand of what we do know of it, it is a different, it occurs for a different reason. It's not necessarily an overactive immune response, though patients with any kind of autoimmune disease tend to be at higher risk for it. So I wouldn't think that it necessarily correlated with, but that study hasn't been done as far as I know. Other questions? All right, thank you, everybody.